All right, so these are called Chinese finger traps, and what you do is you jam your fingers right in there, as deep as they can go. So what's the secret to getting out of these things? Push in. It's a paradox, right? Push in, move slowly, a little bit of flexibility, and you can, without the use of your thumbs, you can work your way out of this thing. This is an experiential exercise, a metaphor that we do with patients, and we ask them about the experiences you all had. They say the same thing. What's your immediate reaction when you notice you're stuck? Fight a little bit harder, get a little bit more stuck, or fight a little harder, get a bit more stucker. We ask things like, are there parallels between this and your typical reactions to pain? When pain shows up, do you immediately do this? And does it dig its claws into you a little bit deeper? Are you with me here? We also, if you're a psychologist, the trick in chronic pain is always to start to sneak emotions and thoughts into the conversation without doing it in such a way that they give you the fuck off, whatever Lorimer said this morning, right? Sneak it in there. So we can say it in this way. What about the emotions that pain occasions, the emotions that come along with pain? Things like fear, depression. Is there a principle here that is common? That when we notice distress, we fight a little bit harder and it can get us a little bit more stuck. And we use this just as a way of starting the conversation. Starting the conversation to try and enhance some awareness here about I tried to point, I pulled hard, I got stuck. To try and point out that the consequences of fighting harder, in this case, are not the consequences we want. In fact, the consequences we want require us to do something a bit paradoxical, which is to push in to the experience, to begin to move a little bit more flexibly with the experience, to move a little bit more gently. And if we do that, at some point, we get some flexibility. Here's function number 2, which has to do with what I spoke about earlier in clinical behavior or clinician behavior, which is that if something feels aversive, as human beings, we'll tend to run away from it. And our pain patients are generally fairly skilled at this, right? At avoiding their behavioral repertoire, which involves avoidance of distress and pain, is generally very well established. And it is persistent across time and situation. And the issue here is that sometimes they have fairly poor discrimination of what is an aversive that is threatening and should be run away from. That's not English. Should be avoided. And what is an aversive experience that doesn't need to be avoided in such a persistent way? We might say this is something like poor discrimination, or if we were being geeky behavior analysts, we would say it's poor stimulus control or inappropriate stimulus control. In other words, something is showing up in their experience that is saying danger, danger, danger. Or something is showing up in their experience that is not showing danger, and they're running away from it regardless. One of the problems with human beings is that we have brains. One of the problems with human beings is that we have thoughts and feelings. One of the problems with human beings is that we work very hard to try and avoid thoughts and feelings, and that it's very hard to avoid things that are in our own head.